coming to the intestine. In this intestine, the important points you have to know is regarding the type of intestinal ulcers. Intestinal ulcers. In case of TB, how will be the intestinal ulcer? Transverse, circumferential ulcer with strictures. And mesenteric lymph nodes can be involved in this. Then Crohn's disease. How will be the ulcer in Crohn's disease? It will be a longitudinal ulcer. How about in amoebic ulcers? What is the shape of the amoebic ulcer? Come on. What will be the shape of amoebic ulcer? Flask shaped. Amoebic ulcers will be flask shaped. So this could be the hint that you can have in MCQs. Then regarding the tumors that in the stomach and the intestine. What is the most common benign tumor of the stomach? The answer is leiomyoma. What is the most common malignant tumor of the stomach? It is adenocarcinoma. What is the most common malignant stomach tumor that bleeds? It is what? Leiomyosarcoma. Then most common mesenchymal tumor of the stomach. Most common mesenchymal tumor of the stomach is the gastrointestinal stomal tumors are the most common mesenchymal tumors of the stomach. The other diseases that is more important in the intestine is in the large intestine is the inflammatory bowel diseases, which is nothing but ulcerative colitis and Crohn's disease. Ulcerative colitis and Crohn's disease. If you see the picture itself, you can tell me the difference between ulcerative colitis and Crohn's disease. First one, which disease is comparing both the diseases, which is safe to have? Which one you want to it's safe to have this particular disease? Which one will you suggest? Crohn's disease or ulcerative colitis? Come on. Ulcerative colitis is a safer disease because when the colon, this is a part of the colon is involved, right? If you go for a colectomy, I agree that ulcerative colitis has a high chances of going for a colonic carcinoma. So even if you go for a colectomy, there is not much problem that is going to happen. The patient can survive in a normal condition. Whereas this Crohn's disease is here and there. So it is a skip lesion. Skip lesion is there in Crohn's disease, and hence it makes the treatment of disease to be very difficult. What are the differences that you know of? This is a skip lesion. Here, this one, ulcerative colitis, you can call as backwash ileitis. backwash ileitis, and it looks like a lead pipe, right? So it is called as a lead pipe. It has a lead pipe appearance on the chest X-ray. And this colon part is involved, right? It's called as the toxic megacolon. Mostly ulcerative colitis is P ANCA positive, whereas Crohn's disease is A ANCA positive. And this Crohn's disease has a high chance of perianal fistula. Since it is all patchy, and from the inside in colonoscopy, you will have the cobblestone mucosa in colonoscopy. And it looks like a string of contour. String sign of contour will be seen in X-ray. These are the main differentiating features between the Crohn's disease and ulcerative colitis. I will, on further discussion, ulcerative colitis, most common site is the rectum. We already saw. Crohn's disease, terminal ileum is the most common site. Bloody diarrhea will be ulcerative colitis. Crampy abdominal pain will be the main symptom. Very important thing is the thickness of inflammation. It is only at the mucosa level, whereas in Crohn's disease, is transmural thickening is there, and hence it makes it very difficult for this for the treatment of Crohn's disease. Fistulas and obstructions and abscesses are very common with Crohn's disease, whereas toxic megacolon is common with ulcerative colitis. Then we already saw Crohn's disease is a skip lesion, discontinuous lesion. And the treatment is both basically sulfasalazine, 5-aminosulfuric immunosuppressants, basically 5-aminosulfuric acid, sulfasalazine are the main treatment for both the ulcerative colitis and Crohn's disease. Then coming to few esophageal disorders. What is achalasia cardia? Achalasia. Achalasia is the most common motility disorder. It is basically the problem is the nervous system, the myelin plexus that is present in the esophageal wall that is degenerated. So because of this degeneration, there is failure of relaxation of the lower esophageal sphincter, and there is also loss of peristalsis in the distal esophagus. This is the main pathology behind it. So because of all these things, these patients will have dysphagia. Dysphagia will be more for liquids than the solids. On barium swallow, what will be the pattern? On barium swallow, you will have bird beak appearance. Bird beak appearance. How do you treat it? Achalasia cardia is basically treated by, first thing, they will try Botox injection in that particular area. That is, the botulinum toxin is injected inside the lower esophageal sphincter for relaxation. Or you can go for a pneumatic dilation of the lower esophageal sphincter. Then modified Heller's myotomy. Modified Heller's myotomy. Or the recent surgery is the POEM, per oral endoscopic myotomy. This will help up in opening the muscle layer for the relaxation of the lower esophageal sphincter. This then comes the other one is the esophagitis. Esophagitis, the most common cause of esophagitis is what? Esophagitis is nothing but inflammation of the esophagus. GERD is the most common cause of esophagitis. If you ask me what is the most common infective cause, it could be cytomegalovirus most probably, then candida, candidiasis, and then herpes. Okay, then coming to one disease called as the Plummer-Vinson syndrome. What is a triad of Plummer-Vinson syndrome? Dysphagia, iron deficiency anemia, and esophageal webs. Usually, this patient will present with painless dysphagia. This patient will present with painless dysphagia, and there are high chances of squamous cell carcinoma. In this area where there is a Plummer-Vinson syndrome, and these patients on a long term, they have anemia. Already iron deficiency anemia is a path of trend. Treatment for long-term treatment could be esophageal dilatation, along with iron supplementation. Esophageal dilatation along with iron supplementation. Then what is Barrett's esophagus? Please tell me the answer. Barrett's esophagus. This is very easy. Anyone?
A metastasis in the esophageal epithelium.
Yes, what is a normal esophageal epithelium?
Squamous epithelium, ma'am.
Normal squamous epithelium. This will become
Columnar.
metastasized into
Columnar
columnar
epithelium.
Columnar epithelium. This is called as the Barrett's esophagus. What is the cause of Barrett's esophagus? GERD is the most common cause of Barrett's esophagus, and there is a high risk of progression to adenocarcinoma. How do you want to treat it? Treatment is basically the proton pump inhibitors, which will prevent the GERD. That is the treatment. The drug of choice would be proton pump inhibitors. If you ask the procedure of choice, I can say that you can do an endoscopic resection followed by an ablation. But the main treatment of choice would be proton pump inhibitors. Then what other? In esophagus, you have another syndrome called as Gorham syndrome. What is that? Gorham syndrome. It is because of forceful vomiting against a closed glottis. Because of forceful vomiting against a closed glottis, what will happen? There will be a complete transmural rupture of the esophagus. Okay, this patient will present with vomiting history, lower chest pain, and subcutaneous emphysema. What is this triad called? It's called the Meckler's triad. is called the necklace triad. How do you want to treat it? Before treating, investigation of choice would be a contrast esophagogram. Treatment would be mostly conservative healing. If not, if the rupture is too much, they might go for a surgical procedure. Then GERD. What is GERD? Gastric esophageal reflux disease. The most common disease almost every one of us have. Causes of GERD. The main cause would be genetic. The second main cause would be H. pylori. Third thing, obesity, pregnancy, or overeating would be the causes of GERD. This, how will the GERD ideally present? There are many ways of presenting. Ideally, it presents with a retrosternal pain, chest pain, along with a sour smelling breath, along with a tooth discoloration. Severe GERD will present like this only. Investigation of choice for GERD would be a 24 hours pH monitoring. 24 hours pH monitoring. And complications would be aspiration, bleeding, or an esophageal carcinoma. And the treatment would be mainly antacids, proton pump inhibitors, or a H2 blocker. And the surgery would be Nissen's fundoplication. Nissen's fundoplication. Okay. So this is what is regarding the GERD. Then coming to some ulcers, peptic ulcer disease, which is very common. The most common site of peptic ulcer disease, answer please. Answer for most common site of peptic ulcer disease. Come on. You people there?
Yes, sir.
Lesser curvature.
Duodenal cap. Duodenal cap is a more frequent site than the lesser curvature of stomach. Okay. Then the protective factors would be the prostaglandins. Damaging factor would be the HCl. Just a minute, 1 minute. Damaging factor will be HCl. The two types of peptic ulcer disease that you have could be either a duodenal ulcer or a gastric ulcer. And the investigation of choice is you do a upper GA endoscopy along with biopsy. Most common complication that can happen because of this duodenal ulcer is perforation, one thing, And second thing, most common is perforation. Second thing, when it is in the posteriorly, it can lead to bleeding also. The bleeding will be from the gastroduodenal artery. What is the treatment of choice for peptic ulcer disease? If the peptic ulcer disease is due to H. pylori, then the treatment would be triple therapy with the tetracycline, metronidazole, and PPI. If only a peptic ulcer, the choice would be proton pump inhibitors. Then coming to the liver disorders, what is hemochromatosis? Hemochromatosis is basically excess deposition of iron in the liver and the pancreas. And the classical triad would be cirrhosis of the liver with the bronzing of the skin along with diabetic mellitus. Diabetic mellitus is mainly because of a deposit of iron in the pancreas, islet cells. When the iron get deposited, they can't release insulin properly, thereby they end up having diabetic mellitus. Usually, the liver is the first organ to be affected, and these patients, how do you find out the earliest manifestation? Earliest manifestation is by increased transferrin saturation. Increased transferrin saturation. How do you treat? It's by iron chelating agents like desferoxamine, desferoxamine, and if not that, then you have to go for phlebotomy. Phlebotomy is removing a particular unit of blood from your body so that the iron is flushed out from the body. Next, coming to Wilson's disease. What is the Wilson's disease? Morning, I think I told you a single word about Wilson's disease. Tell me the chemical involved. What is the chemical involved in this Wilson's disease?
Copper.
Exactly, copper. So the problem with is the mutation of ATP7B gene located in chromosome 13. This is the reason for this mutation. Wilson's disease. What happens? Mainly the problem is the copper is not able to be metabolized. So the serum ceruloplasmin levels will be low. So the copper will get deposited in the liver. So when it gets deposited in the liver, it causes fatty change, cirrhosis, and acute fulminant hepatitis. So the gold standard investigation could be liver biopsy, or a quantitative assay of copper. Quantitative assay of copper. What exactly do you measure? In the quantitative assay of copper, usually there will be increased 24 hours urine copper, and there will be decreased serum ceruloplasmin, which is the carrier of copper inside the body. Decreased ceruloplasmin levels in the serum. That means that more ceruloplasmin is attached to the copper to become a molecule, copper molecule as such. So very less ceruloplasmin is left out without attaching copper. That is the meaning for this. So how do you treat it? Treatment of choice would be copper chelating agent like oral penicillamine. Copper chelating agents like oral penicillamine, If the patient is allergic to penicillamine, what will you do? You have to treat the patient with Friantin. If the patient is pregnant, you have to treat the patient with zinc. If the patient is pregnant, you have to treat the patient with zinc. So this is what is regarding the what else? Cholecystitis will be covered in surgery. We'll see about this pancreatitis. Most common causes of pancreatitis: acute pancreatitis, most common cause, you can remember it as get smashed. Gallstones, ethanol, trauma, steroids, mumps, autoimmune cause. Then serum lipid levels will be more. Hyperlipidemia, ERCP, then drugs like azathioprine, estrogen, furosemide. All these things, tetracyclines, can cause an acute pancreatitis. How do you treat an acute pancreatitis? You take the patient's NPO so that there is a rest to the pancreatic enzyme. If there is too much of secretion, you go for a nasogastric tube suctioning. Nasogastric tube suctioning. So, of course, for energy, you need some IV fluids. IV fluids along with IV analgesics for pain relief. The IV fluid of choice would be ringalactate, and IV analgesic of choice, it depends upon the patient. Mostly opioids are used. Pethidine or meperidine is used in the relieving of the pancreatitis pain. Then coming to some intestinal disorders, you have to know about intestinal TB. Intestinal TB, what will be the symptoms? The patient will, of course, present with abdomen pain, then anemia, then TB, other TB symptoms, plus possibility of obstruction is there for the patient. And most common region where the intestinal TB happens is the ileum or the ileocecal region. Pathological finding. What is the patho finding? You take a biopsy of that area, use the pathological finding, there will be increased Peyer's patch in that area. There will be increased Peyer's patch in the distal and the terminal ileum. Peyer's patch is basically macrophages, inflammatory marker-rich area. The lymphocyte-rich area is called as the Peyer's patch. And these patients will have perpendicular ulcers. That is a very important point to be noted. Perpendicular ulcers. Intestinal TB ulcers are perpendicular ulcers, and when you take a biopsy, these patients have high chances of having a caseating granuloma. Most common complication that can arise in this type of intestinal TB is a bowel obstruction, of course. Bowel obstruction more than perforation and bleeding. These things are the things to be noted in intestinal TB. Then the other thing in the intestine would be Meckel's diverticulum. Meckel's diverticulum, you have to know it is a true diverticulum. First point, it is a true diverticulum. That means to say that all the layers of the intestine, that is the mucosa, submucosa, muscularis mucosa, the muscle layer, and the outer serosa, all the layers will come out. That is a diverticulum, and it is a remnant of the omphalomescentric duct or the Bettelin duct, and it is 2 inches long, 2 feet from the ileocecal valve, and it is present in 2% of the population, and it is mostly present in first 2 years of age. Then 2 types of epithelia, gastric and pancreatic epithelium could be seen in the Meckel's diverticulum. And how do you, if it is causing some problem, you go for a laparoscopic resection and then proceed further. Unless this is a problem, you don't have to operate on it. So when I spoke about true diverticulum, there is something called false diverticulum also. That means to say that only the mucosa and submucosa will outpouch in case of a false diverticulum. In true, all the layers will outpouch. Then disease that you have to know is that celiac disease. Celiac disease, it is also known as gluten sensitive enteropathy. Gluten sensitive enteropathy. The typical clinical features would be weight loss, chronic diarrhea, abdomen distension, and growth retardation. This will be the clinical features, and what will be the diagnostic test? Diagnostic test is IgA tissue transglutaminase. IgA tissue transglutaminase. And the confirmatory test, how do you confirm it? You basically do a endoscopy and go for a duodenal biopsy. And the most common disease associated, diseases, dermatitis herpetiformis. That is a cutaneous variant of the celiac disease is this dermatitis herpetiformis. Okay, how do you treat? Treatment is basically gluten-free diet. Gluten-free diet is the only option for surviving. And what are the gluten-free diet? What should be avoided? Barley should be avoided. Oats, wheat, I forgot. I think it's ragi or something. I'm not sure. It is these are the glutens that has to be avoided in case of a celiac disease. If apart from the gluten-free diet, you can put them on supplements, dietary supplements like iron, calcium, and vitamins, and along with some immunosuppressive steroids, and further proceed. So this is what is regarding the intestinal disorders. Okay. Next, coming to the cardiac system. In cardiac system, you have to know about the few important things like myocardial changes that happens inside in a light microscopic picture in case of an MI. What are the changes that happens in MI in a light microscopic picture? In 90 minutes to 4 hours, within 4 hours, there will be only wavy fibers in the border, wavy fibers at the heart border. In almost half a day, the coagulative necrosis begins. And hence, it is always safe to go for an angioplasty before 4 hours so that we can prevent the necrosis from happening for the patient. In 12 to 24 hours within a day, this coagulative necrosis, along with the neutrophils, will start to act on this area. Necrosis, I told you, it will cause inflammation, right? So the first person to come in inflammation and acute inflammation will be the neutrophils. So the neutrophils start coming inside. In 1 to 3 days, there will be coagulative necrosis with a full-fledged neutrophils in that area. In 3 to 7 days, slowly this acute inflammation will start becoming a chronic inflammation. That is, in 3 to 7 days, the neutrophils will start dying neutrophils, along with the starting of phagocytosis by the macrophages. Then in 7 to 10 days, it has become a chronic inflammation where you have a phagocytosis process actively happening along with the granulation tissue formation. Whenever there is a granulation tissue, it becomes a chronic inflammation. Then in 10 to 14 days, that is in 2 weeks, this granulation tissue will further cause neovascularization, thereby and also increase the collagen deposits. Whenever the collagen deposits, the next thing that is going to happen is the formation of fibrosis, that is the scar formation starts. Scar formation starts. Increased collagen will increase the scar formation, and once the scar starts, there is a decreased cellularity in that area, thereby reducing the cardiac pumping effect. When it is more than 8 weeks, proper dense scar is formed. So thereby, the scar will further reduce the entire active myocardial cells that is participating in the cardiac pumping, thereby leading to the cardiac failure in these patients who are not treated during this myocardial infarction period. Then, in the most common cause of MI in child, most common cause of MI in child is what? Kawasaki's disease. Most common cause of MI in adult. What is the most common cause of MI in adult? Are you people there?
Yes, ma'am.
You're there, right? Come on, someone. Divya, what is the most common cause of MI in an adult?
Atherosclerosis.
Exactly, atherosclerosis. What is the most common late complication of an acute MI which is untreated? It is ventricular aneurysm. Ventricular aneurysm. What is the most common cause of death in acute MI? Most common cause of death in acute MI is ventricular tachycardia, followed by ventricular fibrillation. What is the most specific marker for MI?
PKM.
What is the most specific marker for MI? Sorry? Come on. Troponin.
Triphenyl tetrasodium chloride.
Sorry, come again.
Triphenyl tetrasodium chloride.
I don't know what is that. I'm asking about the most specific blood test marker that you used for MI. That is troponin T, which is a component of the cardiac muscle that gets released during the destruction of the cardiac muscle. So that is troponin T. I think you told me about tetrasodium, right? That means that it is the cardiac muscle marker in a pathological state. In histopathology, that could be the answer, but I meant in the blood test after an MI in a blood test, the specific marker would be troponin T. When we spoke about his ventricular aneurysm, there are other aneurysms also that you have to know of. What are the different types of aneurysms that you know of? First, Berry's aneurysm. Berry's aneurysm will be like this. It will mostly present in the circle of Willis. Where is the circle of Willis seen?
Brain.
Where is the circle of Willis seen? Yes, exactly, brain. Microaneurysm. Microaneurysms are seen in diabetes and hypertension. Mycotic aneurysms. Mycotic aneurysms are seen in bacterial infection. Aortic dissecting aneurysm. Aortic dissecting aneurysm is mainly because of the degeneration of the tunica media. And in which all conditions do you see it? You see it in Marfan syndrome. You see it in Marfan syndrome and hypertension. Then the syphilitic aneurysm, it is seen in which vessel? It is most commonly seen in which vessel? Syphilitic aneurysm. Syphilitic aneurysm, it's most commonly seen in the ascending aorta. This is all MCQs. This part is a very important MCQ. Ascending aorta, syphilitic aneurysm is very common. Then other parts like what is cardiac tamponade? Cardiac tamponade. Come on, what is cardiac tamponade?
Due to pericardial effusion.
There is accumulation of fluid in the pericardial sac that is causing the restriction of pumping of the heart. Then it is a cardiac tamponade. What is the triad which is involved in cardiac tamponade? That is the Beck's triad. This Beck triad, what is the triad? Hypotension, distended neck veins, and muffled heart sounds. muffled heart sounds. This is the triad of cardiac tamponade. Then in the heart, what is the most common cardiac tumor that you know of? Most common cardiac tumor is mainly metastasis. Okay. Then if I ask you most common primary cardiac tumor, if it's primary means it is atrial myxoma. Primary cardiac tumor in a child will be rhabdomyoma. Okay, these are the things that you have to know in the heart. Apart from this, you have to know about the types of hypertrophy. Normal heart will be like this. Concentric hypertrophy means there is an increase in the left ventricular mass, but the normal cavity size will be normal. Normal left ventricular cavity size, and there will be an increased left ventricular wall thickness. This is called as the concentric hypertrophy. The concentric hypertrophy, the main pathophysiology here is the pressure overload. And there will be preserved. In this concentric hypertrophy, the patient will have a heart failure with a preserved ejection fraction. So, that is normal ejection fraction will be there for this patient. Examples of concentric hypertrophy, any idea? Aortic stenosis, in that you have left ventricular hypertrophy. Pulmonic stenosis, you have right ventricular hypertrophy. Pulmonary hypertension, in that you have right ventricular hypertrophy. And normal regular systemic in hypertension, in this you have left ventricular hypertrophy. So this is what is regarding concentric hypertrophy. Then what is eccentric? Here in an eccentric hypertrophy, there will be an increase in the left ventricular mass. Along with that, there is an increase in the left ventricular cavity size. And the walls of the ventricle will be almost normal walls. Okay, this is called as eccentric hypertrophy. The main pathophysiology here would be volume overload. Volume overload. And the examples of eccentric hypertrophy, and before they going for example, these patients will have a reduced ejection fraction. They will have a reduced ejection fraction. Examples: athletic heart syndrome, aortic regurgitation, and mitral regurgitation. These are the possible things that can happen. These are the possible examples in which an eccentric cardiac hypertrophy will happen. Then that's all regarding the heart. After this, we will proceed for the renal system. In renal system, I hope the screen is visible now. Is my screen visible?
Yes, ma'am.
Okay. Okay, I will try to wrap up as much as possible. I think it has been almost 3.5 hours. We have only two systems remaining. One is the renal system and the other one is the CNS. I'll finish off as much early as possible. I'll go a little fast also. So in renal system, the two things which is of concern to us is the nephritic syndrome and the nephrotic syndrome. You have to know the difference between nephritic syndrome and the nephrotic syndrome. The nephritic syndrome What is the main classical feature? Here you will have hematuria. And proteinuria will also be there. A little proteins will be there, not too much. Okay. The patient will have hypertension along with the low urine output, oliguria. Whereas in a nephrotic syndrome, these patients will have mainly proteinuria. Because of proteinuria, that is almost more than 3 grams in 24 hours, they will lose more than 3 grams in 24 hours. And the urine will look more frothy because of the protein. The patients will have hypoalbuminemia because of the loss of proteins in the urine. Then edema and hyperlipidemia. The edema is because of the loss of proteins. Hyperlipidemia is a feature. So this will be the difference between the nephritic and the nephrotic syndrome. Now we have to read each and every diseases which comes under this nephritic and nephrotic syndrome. If it's nephritic syndrome, it is examples is post-streptococcal, glomerulonephritis, then rapidly progressive glomerulonephritis and IgA nephropathy. This will be the example of nephritic syndrome, whereas nephrotic syndrome example would be minimal change disease, focal segmental glomerulonephritis, membranous glomerulonephritis. And this could be the primary cause. The secondary causes for nephrotic syndrome, it could be SLE, hepatitis B and C, HIV, then diabetic mellitus and malignancy. Okay, so if you take each and every one in the streptococcal, what usually is streptococcal infection is a throat infection, right? Upper respiratory tract infection. After upper respiratory tract infection, this exotoxin B will be released inside the circulation, and that in turn will form this immune complex which gets deposited in the glomeruli, thereby causing inflammation and further leading to a subepithelial side inflammation, more progressive disease of the subepithelial side, thereby leading to a hypercellular glomeruli. This is the post-streptococcal glomerular nephritis. Usually, because of this hypercellular glomeruli, there will be obliteration of the capillary lumen, thereby producing thereby leading to the nephritic syndrome that we spoke of. This is post-streptococcal glomerular nephritis. If you ask me the theory questions, usually the deposits that will be there in the kidney could be IgG, IgM, and C3 are the deposits that we see in the mesangium as well as in the basement membrane. And usually what happens, there is a lab features would be decrease in serum C3, and there will be an elevated ASO titer, anti-streptococcal antigen titers. Okay, and more than 95% people will recover spontaneously without any treatment. It's a conservative therapy. Just give fluids, patient will recover. This is post-streptococcal glomerulonephritis. Next is rapidly progressive glomerulonephritis. Here, what happens? The cause is the progression of the disease will be very fast, and they form crescent-like formations will be present. See, if there is a glomerulus like this, the disease will have this crescent pattern. This area will be affected. So this crescent pattern will be there in rapidly progressive glomerular nephritis, and it progresses over a very short period of time. It is mainly because of the immune complex mediated problem. And this rapidly progressive glomerular nephritis has the worst prognosis. This rapidly progressive glomerular nephritis can be of many types. One such type is immune complex mediated. Second thing is anti-glomerular basement membrane mediated. Third thing is the quasi-immune mediated. Quasi-immune mediated is basically ANCA positive one. That is enough for you. This is enough. If you know this thing, this is enough. If you are want to be more specific, remember this electron microscopic picture, sorry, fluorescent picture, so that it helps you in identifying in case of any MCQs. Next is the we spoke about the RPGN. Next, coming to the nephrotic diseases, that is the minimal change disease. Usually there is a diffuse effacement of the podocytes. This is the effacement of normal podocyte is this one. There will be flattening of the podocytes in case of a minimal change disease. Because of this, in this gap, the protein gets out, thereby causing proteinuria. Next is among the nephrotic syndrome is that diabetic is a secondary cause of nephrotic syndrome, right? In diabetic, you have to know about the light microscopic picture. In that light microscopic picture, you have to know these 2 points. The laminated appearance of Wimmelstiels-Wilson nodules is characteristic of nodular sclerosis due to diabetic. Diabetic nephropathy means Wimmelstiel-Wilson nodule. You have to remember this. And second thing, there is an arterioral hyalination. This is the arterioral hyalination. This part is right? This one, this is an arterioral hyalination. This is the arteriolar hyalination. This is all helps to detect the diabetic nephropathy. Then coming to systemic lupus nephritis, of course, it is also a cause of the things. Here there will be destruction of the capillary wall, and there is an increased mesangial matrix and thickening of the capillary wall. These patients will have, it is an autoimmune disorder, right? So lupus nephritis will be a part of the SLE, not SLE as such. This is a IgA nephropathy. In IgA nephropathy, there will be IgA deposits in the mesangial layer. You can see these layers, right? Fluorescent layers. This is basically IgA deposits in the mesangial layer. Mesangial region. And these patients, of course, they are also present with hematuria and proteinuria because it is a nephritic syndrome pattern. Nephritic syndrome pattern, so hematuria and proteinuria both will be present. Then this is, see, if you look at the big glomeruli, among the big glomeruli, only this part is represented. So I say it as a focal segmental glomerulosclerosis. Only this part of the glomerulus is sclerosed, calling it as a focal segmental glomerulosclerosis. The most common cause is idiopathic, and of course it causes nephrotic syndrome with a non-selective proteinuria. Then there is something called membranous proliferative glomerulonephritis. It can present as both nephrotic or a nephritic syndrome or both together. Okay, there are 3 types of MPGN. Type 1 is mostly associated with hepatitis B virus and SLE. Here the main point is glomerular membrane is thickened, and the proliferation of mesangium causes tramp tracking by splitting of the glomerular basement membrane. Like if the glomerulus is like this, what will happen? The glomerular basement membrane is ideally should be almost near that area. But in case of this membranous glomerulonephritis, MPGN, there will be the glomerular basement membrane will be away from that area. It is like a tram track is produced in a tram can go in this area. Tram track, it will be split up from the base. That is the tram tracking sign that is seen in membranoproliferative glomerulonephritis. In all the MPGN, you have this tram tracking. Next, type 2 is because of the C3 nephritic factors. Third, MP3 It is not, it is very rare, and it is recently under study. MPGN3 is recently under study. And the main feature of this MPGN is persistent, entire persistent hypocomplementemia. Persistent hypocomplementemia. Hypocomplements will be present in case of this membranoproliferative glomerulonephritis. Okay, then coming to this one. This is the renal cell carcinomas. What are the different types of renal cell carcinomas? What the major risk factor for renal cell carcinoma is tobacco. What is the triad of renal cell carcinoma, or the classical feature? Palpable mass, osteovertebral pain, and hematuria. Okay, this will be the renal cell carcinoma. The investigation of choice would be CT guided biopsy. And the different types would be this clear cell type, papillary type, medullary type, or the collecting medullary type, and then this chromophobe type. This is the most commonly involved. If you see the different points in this each carcinomas, clear cell is the most common, as it is clearly depicted here. It is the most common. Second thing, it is mostly arise from the proximal convoluted tubule, and is because of the deletion and translocation seen in chromosome 3p, and it is a unilateral solitary tumor. Second thing, papillary cancer. It's a cancer that is mostly associated with the dialysis associated disease. Dialysis associated cystic disease. Dialysis associated cystic disease. It mostly arises from the distal convoluted tubule, and it is a multiple tumor with the bilateral involvement, and psammoma bodies will be present. P for psammoma. Bodies will be seen. Then chromophobe, it is mainly from the arises from the eye cells, intercalated cells, and then it has got multiple chromosomal loss. And extreme hypoploidy will be seen. Extreme hypodiploidy will be seen in case of chromophobe renal carcinoma. Collecting the carcinoma, it is a highly atypical epithelium with a hobnail pattern. And it is the most aggressive with the worst prognosis. Highly aggressive with the worst prognosis. This is what is regarding the kidneys. Then coming to the last topic of the day, that is the CNS. In CNS, you have to know about meningitis, which is very important. Meningitis is usually divided, like you can say when it is less than 4 weeks, we call it as an acute meningitis. When it is more than 4 weeks, you call it as chronic meningitis. And when do you call it as recurrent? You call multiple acute episodes along with the duration more than 4 weeks, you call it as recurrent meningitis. So this is how meningitis. Usually this meningitis will further infect the remaining areas like the heart, pericarditis, arthritis, ocular infections, pneumonia, and cutaneous infection. And basically, how do you want to investigate it? Investigation of choice would be CSF analysis. Depending on the CSF analysis only, you further decide what will be the treatment plan, because we have to know whether it is a bacterial meningitis or a viral meningitis. Depending on how it is, you have to decide about it. Normally, normal CSF will have 0 to 5 lymphocytes. And 45 to 85 glucose level, milligram per deciliter. This is for hyperfill. Then protein will be around 15 to 45 milligram per deciliter. And the opening pressures will be 70 to 180 millimeters of water. 70 to 180 millimeters of water. This is how a normal, this thing will be normal CSF would be. In case of a bacterial infection or a pure bacterial meningitis, bacteria means, of course, the inflammation, so you will have increased polymorphonucleosis. The neutrophils will be increased. Because of the bacteria, it will utilize all the glucose, so there will be low glucose. And too much of the bacteria will contain protein inside it, right? I'm just telling you for hint of remembering. So more proteins. And too much of bacteria, so opening pressure will be high. Remember it like this. This is regarding bacterial meningitis. Then granulomatous meningitis. Like mycobacterial, like TB and fungal. Granulomatous meningitis, mycobacterial and fungal infections. In those patients, 100 to 1000 cells per high power field. And here also the glucose will be less, protein will be more. A little elevation of the pressure will be there. This is marked elevation, it is moderate elevation. In case of viral meningitis or the aseptic meningitis, 25 to 2000 cells will be there. The glucose will be normal or low, and the protein will be high, and this will also be slightly elevated. Okay, only depending upon this, you will have to come to a conclusion about how much will be, what is the type of meningitis that the patient has. So this is what is regarding the meningitis. Next, coming to neurodegenerative. I think we'll deal with the neurodegenerative disorders in the medicine part, because medicine part has this, we'll deal in detail in the medicine. Nothing much of a pathology is there in that one. We'll do the tumors of the CNS alone. CNS tumors. CNS tumors, glioblastoma multiforme. It is a highly malignant primary tumor of the brain. 1 year is the median survival rate. Found in the cerebral hemisphere, and it also crosses the corpus luteum. And the main histology here is the pseudo-palisating with the pleomorphic tumor cells. Pseudo-palisating with pleomorphic means different sizes. The size will not be same. Pleomorphic tumor cells. Okay, then meningioma. Meningioma is the most common benign primary tumor. Most common benign primary tumor. Female is more than male chances. And here the histopathology will be spindle-shaped cells will be there. Spindle-shaped cells arranged in a walled pattern will be there. Then hemangioblastoma. Hemangioblastoma is most commonly found in the cerebellum, associated with the von Hippel-Lindau syndrome, and it is also found with retinal angiomas. Then oligodendroglioma. Oligodendroglioma is basically a slow-growing tumor. It is often present in the frontal lobes, and it has a chicken wire capillary pattern. Chicken wire capillary pattern, and it has got the cells will have a fried egg appearance of the cells. Fried egg appearance of the cells. This next two things that you have to know is the medulloblastoma. Medulloblastoma is the most common primary malignant tumor in children. Highly malignant cerebral tumor. Okay, cerebellar tumor, and usually the growth compresses the fourth ventricle, leading to hydrocephalus. And histopathological finding would be the patient is having Omar-Wright's rosette. Omar-Wright rosettes will be the histopathological finding. Then coming to the last carcinoma that you have to know is the craniopharyngioma. Craniopharyngioma. The craniopharyngioma is a benign childhood tumor. And it is the most common supratentorial tumor in childhood. It is the most common supratentorial tumor in childhood. Histopathologically, and also it is derived from the remnants of Rathke's pouch. Derived from the remnant of Rathke's pouch. Histopathological examination includes the tooth enamel like. This is what is regarding the CNS tumors. Then for summary at the end, the last session, you have to know about the few tumors of the liver. Most common liver tumor. Liver tumor most common is metastasis. Most common benign tumor of liver would be cavernous hemangioma. Cavernous hemangioma. Then spleen. Most common tumor, it is benign. Most common tumor will be hemangioma. Whereas most common malignant tumor would be lymphoma. Okay. This is what is regarding the liver and the spleen. Then you have to know about few named bodies in the body, which I will send you a list. You have to read it yourself. It is a big list. In the big list, you have to find out, I mean, at least you try to read those lists and remember the content. For example, I'll tell you a few ones. Schiller-Duval bodies are seen in Schiller-Duval bodies. Seen in, answer please. Seen in? Are you people there?
Yes.
Tell me the answer. Schiller-Duval bodies are seen in endodermal sinus tumors or the yolk sac tumor. Endodermal sinus tumor or the yolk sac tumor. Hall-Hexner bodies. These are all very important. Hall-Hexner bodies are seen in granulosa cell tumor. Samoma bodies, I already told you. Where is Samoma body seen? Where is the Samoma body seen? I told you, right? Papillary. Papillary carcinoma.
Papillary
venous cell
carcinoma of renal.
carcinoma. Then papillary carcinoma of thyroid. Then serous cystadenoma.
Meningioma.
Then meningioma. In all these things, you see this Samoma bodies. Crayola bodies are seen in the lungs. In which disease? Seen in the lungs in the asthma. Right? Lephora bodies. Lephora bodies are seen in the muscles in myoclonic epilepsy. I think it's not in the muscles, it's in the nervous system, Lephora bodies. Lewy bodies in the CNS, seen in Parkinson's disease. Right? Russell's bodies. Russell's bodies are seen in the blood. It is seen in multiple myeloma. Then Hounsellman bodies, where is it seen? Hounsellman bodies are seen in the liver in case of viral hepatitis. Ferruginous bodies. Ferruginous bodies are seen in the lungs in asbestosis. Then Hirano bodies. Hirano bodies are seen in the brain in Alzheimer's. Civet bodies are seen in the skin in lichen planus. Gamma antibodies, where are they seen? Answer, gamma antibodies. You cannot forget gamma antibodies. When we read pathology, gamma antibodies used to be a fancy name, right? How can we forget it? Gamma antibodies are iron and calcium containing cells that is present in the spleen. Okay. Next, regarding few cells, hobnail cells, where are they seen? Abdominal cells are seen in the ovarian clear cell carcinoma. Ovarian clear cell carcinoma. How about clue cells? Very important question. Clue cells are seen in Gardnerella vaginalis. Spindle cells. Spindle cells are seen mostly in rhabdomyosarcoma. Labor cells are usually seen in trachoma, caused by chlamydia trachomatis. Okay. Then few things. What is Virchow's triad? I forgot to mention in the general pathology. Virchow's triad is venous stasis. Then come on, endothelial injury and hypercoagulability. These are the three things which is called as the Virchow's triad. Third is Virchow's cell. Where is it seen? Virchow's cells are seen in leprosy. What is Virchow-Robin space? Where is it seen? Virchow-Robin space is seen in the brain. What is Virchow's nodes? What is a Virchow's node? Virchow's node, it is basically a supraclavicular node that is present, that is there during malignancies. So this is what is the important things. Then I will ask you a few questions. Anchovy sauce appearance, sauce pus. Anchovy sauce pulse, where do you see it? Anchovy sauce pus, where do you see it? First, you have to tell me the answer. I'm tired of speaking. My throat is gone. Anchovy sauce
Maybe
pus
liver,
is seen
ma'am.
in- Exactly, amoebic hepatitis. Super. Amoebic hepatitis, great. Then what else? Who are blue bloaters? Who are blue bloaters? Blue bloaters are chronic bronchitis patients. Okay, chronic bronchitis patients are blue bloaters. Then what do you call pink puffers?
Emphysema.
Who's pink puffer? Sorry?
Emphysema.
Emphysema, yes. These are all pink puffers. Blue bloaters means they have a deoxygenated blood going inside the body. So that's why they are called blue blockers. Pink puffers is they have the patients will have oxygenation happening inside them, so they won't become blue. So emphysema. Okay. Then what else? Fish mouth stenosis is seen in fish mouth stenosis of the cardiac valves. It is seen in chronic rheumatic heart disease. Okay, chronic rheumatic heart disease. Then, who's the gatekeeper of the heart? Gatekeeper of heart is the AV node. AV node is the gatekeeper of the heart, right? What is the kissing disease? Kissing disease. Come on, first. Kissing disease is infectious mononucleosis. Infectious mononucleosis is a kissing disease. I think we saw about transverse ulcers, right? Transverse ulcers are seen in TB. How about longitudinal ulcers, where it is seen? Longitudinal ulcers are seen in typhoid, in the intestine. Longitudinal offers are seen in the typhoid in the intestine. Then popcorn calcification.
Breast can
Popcorn calcification. Pulmonary hamartoma. Pulmonary hamartoma. Then raspberry tumor. Raspberry tumor is umbilical adenoma. Raspberry tumor is umbilical adenoma. Then tennis racket tumor. Tennis racket tumor, appearance of a tumor. Tennis racket appearance of tumor. It is seen in sarcoma quadrioids. It is seen in sarcoma quadrioids. Then tree barking sign in the aorta. See tree barking sign in thoracic aorta. It's seen in, very important, syphilitic aneurysm. It's seen in syphilitic aneurysm. So I think that's all with the things of pathology. I've tried to cover as much as possible. Still, pathology is a vast subject. You cannot finish in 4 hours definitely. Viscera cells are seen in which disease? Mycosis fungoides. Okay, Caesaric cells are seen in mycosis fungoides. Valve head wall cell nest. Valve head cell nest. Where is it seen? It is seen in the